All right. Thanks, Erica. Thank you for folks who are on and listening, and for anybody who may watch this after the fact. Thank you for joining us. My name is Andrew Wiechert. For anybody who doesn't know me, I am one of the GYN oncologists at Beth Israel Deaconess Medical Center. And I'm going to have the pleasure of talking to our audience today about how we are trying to expand our toolkit to help fight ovarian cancer, and some of the things we're doing, including our new HIPEC program at BIDMC, some of the targeted therapies that we've started to use, and where we're sort of hoping to go next. So first, I want to figure out why my slide won't advance. There we go. First, I want to just acknowledge that we're doing this at the end of September, which is Gynecologic Cancer Awareness Month, and thinking about all of the patients that we take care of and why we come to work every day to try to make life better for these patients, to offer them cure when we can, and to improve their life, even if we can't cure some cases. And these are just some pictures that were taken earlier this month. Our whole division did a fundraiser with the National Ovarian Cancer Coalition to help support patients who are undergoing treatment. And there were tons of survivors there and families there and other caregivers. And it was a great event and a great time being part of a team that I really love. So disclosures, I don't have any financial interest in anything that I'm going to talk about today. Maybe I should get some, but I don't have any currently. Things we're going to go over a little bit of an introduction and background about where things stand for patients who are being treated for ovarian cancer in 2023. And we're going to talk a lot about HIPEC because it's something that I'm really passionate about and something that we're getting ready to start at BIDMC, start to offer to our patients, and hopefully even expand what the opportunities are there going forward. We're going to spend some time talking about one of the newest targeted therapies that's been approved for patients, particularly with platinum-resistant ovarian cancer, that our medical oncology colleagues are now using more and more of. And we'll talk a little bit about that because it's somewhat of a unique drug in the ovarian cancer arsenal and the newest one. So it's, I think, worth going into. We'll talk about a couple of other promising agents that we are starting to utilize in ovarian and other GYN cancers, and some of the other opportunities that are coming up down the pipeline at BIDMC. So where things stand currently for ovarian cancer, we are seeing over the last about 20 to 25 years a very slow but pretty steady decline in the incident number of new cases diagnosed on a yearly basis, which is a great thing to see. Unfortunately, it remains true that while 19,000 patients will develop ovarian cancer in 2023, we estimate that 13,000 patients will ultimately lose their lives in that same amount of time. And so when we look at the annual rate of death compared to the annual rate of new cases, we see that unfortunately a significant too many of our patients are not surviving their disease. And the 5-year survival statistics continue to hover around 50% nationally, which is obviously not as high as we would wish that it could be. But why is the incidence falling? You know, across the spectrum of different cancer disease sites, you hear about increasing rates of cancer in some areas, and increasing rates of cancer in younger patients in some areas. And so why is the incidence falling here? And I think part of it is really the outcome of widely adopted germline genetic testing among patients who have ovarian cancer, that we're identifying more and more patients who carry both high-risk genes like BRCA1 and BRCA2, and some other medium-risk genes like RAD51C or D or PALB2, other things that may increase the risk of ovarian cancer, where we can then do sort of a waterfall cascade of testing in their family and identify patients who are at higher risk and offer them risk-reducing interventions like risk-reducing sublingual oophorectomies, oral contraceptive use, salpingectomies, other things. And so as we become more aware of that, I do think we're making a little bit of a dent in the actual incidence of ovarian cancer, which is really important. But as I said on the previous slide, mortality remains stubbornly much too high at 13,000 women losing their lives every year, and a 50% survival projected only at 5 years overall. So we know we need to keep working to increase survival. If we're not preventing every case of ovarian cancer, what can we do better to help women who are diagnosed with this condition? We always need to ask ourselves that question, and we continue to do so as a specialty and even as a group at BIDMC. And so the sort of good news here is that actually, if you really take a little bit of a longer view, even with the tools that we have used since the mid-1990s, patients are living longer. You know, I put up 3 sort of hallmark clinical trials that were done in different decades that really take patients with advanced stage ovarian cancer. So these are largely stage 3, in some cases stage 4 ovarian cancer in these populations. They're having surgery to treat their ovarian cancer, and they're receiving systemic chemotherapy, and they're receiving, in GOG 111, the intervention was the combination of cisplatin and paclitaxel, a platinum and a taxane. You know, 10 years later in GOG 172, we again used cisplatin and paclitaxel and tried to decide if it was better intravenously or intraperitoneally. And then in GOG 252, we looked at different dosing and route administrations of carboplatin and paclitaxel, whether intravenous or intraperitoneal, or the frequency of intravenous dosing could improve survival. And what I want you to look at is, even in the control arms of each of these studies over the course of 3 decades, the survival got a lot better, right? The median survival for the experimental arm that was an improvement in 1996 was 38 months, whereas the control arm of IV carboplatin had a median survival of 75 months in GOG 252, and those are both trials of advanced stage population patients. So we are adding tools to our toolkits. We're using our tools better. We're benefiting from better supportive care, better management of comorbidities, better surgical outcomes. So even in the tools that we have already in our toolkit, we are doing better, and that's reason for hope and reason for celebration for all of our patients. But clearly there's still room to make improvements, because we still see nationally about a 50% 5-year mortality. So how do we improve this even further? We want the next slide to be the cure for ovarian cancer, but we know that this is a complex biological process, and that, nobody's going to wake up tomorrow morning with the cure for ovarian cancer in their brain. We need to work collaboratively and think creatively about how to use the tools we already know about, and how to use the science that's being done locally and regionally to add new tools to our toolkits. And that's what we're trying to do. And that's sort of some of the things that I want to highlight in the talk today. So one of the biggest challenges that I think we see for our patients when their cancer does reoccur is that the area of the body most at risk is the abdominal cavity. And patients who have an intra-abdominal reoccurrence of ovarian cancer can really get in trouble. And so what we see is that, with ovarian cancer mostly affecting the peritoneal cavity and then going to other parts of the body later, we reflect that upfront in their staging. Patients who have abdominal confined disease, we label their disease as stage 3, versus patients who have disease that's gone beyond the abdominal cavity. That's where we quantify patients or categorize patients as stage 4. And we incorporate the importance of the peritoneal cavity space into some of our surgical resection principles. When we do a cytoreductive surgery for ovarian cancer, we're trying to remove all of these peritoneal deposits and really clean out and sterilize the peritoneal cavity to prevent reoccurrence, particularly in that space, because peritoneal recurrences have this nasty predilection to cause bowel obstructions, which can be a life-limiting problem and complication for a patient over the course of the natural history of their cancer. They may do well if they have small volume disease in lymph nodes or small lung nodules, but if their bowel becomes blocked from carcinomatosis, that is associated with a very poor survival. And so sterilizing the peritoneal cavity and trying to prevent peritoneal recurrences can be a very important part of how we keep patients with this disease alive. And so sterilizing the peritoneal cavity with direct application of intraperitoneal chemotherapy is a concept that's been around, again, for 30 years, and people have been investigating the best ways to try to utilize it. One of the trials that I showed the little survival curve of a few slides ago was GOG 172, which was published in 2006. It was published in the New England Journal of Medicine. And it basically took the same drugs that we were using intravenously for advanced ovarian cancer in patients with stage 3 ovarian cancer, and converted the intraperitoneal exposure converted the platinum exposure and the taxane exposure to intraperitoneal through an access port that was placed along the ribs at the time of their debulking surgery, and then a catheter under the skin would run into the abdominal cavity, and patients would actually get their postoperative chemotherapy partially IV, but most of it was intraperitoneal through that catheter, and they would receive their standard 6 doses of postoperative chemotherapy that way. And the trial showed an improvement in overall survival in patients who received intraperitoneal cancer chemotherapy. And this was such a significant improvement at the time that the National Cancer Institute, the NCI, made a clinical announcement indicating and declaring that intraperitoneal chemotherapy was the preferred method for treating ovarian cancer. And these NCI alerts are not frequent, so this was quite a big deal in 2006 when this came out. There were some challenges with that regimen and with the ongoing utilization and repeated utilization of an indwelling intraperitoneal catheter. Complications of the catheter, such as dislodging the catheter or twisting the reservoir under the skin or otherwise kinking or occluding the catheter, were really common and led to discontinuation of the IP therapy in about 10% of patients in that study and in some follow-up studies. There was increased reporting of abdominal pain and swelling because the chemotherapy was irritating locally to the surfaces where it was being administered. And so as a result of that, there were increased hospitalizations and ER utilizations in subsequent papers that were followed up on the original landmark trial, showing some of the problems that were occurring in trying to really broadly apply this intervention that had worked very, very well in a clinical trial. And then the bigger problem for long-term utilization of IP chemotherapy really came in the mid-2000s at an SGO meeting, and then finally the paper was published in 2019, where the benefit of intraperitoneal chemotherapy on an ongoing basis compared to dose-dense paclitaxel and in patients who were also receiving maintenance therapy was really not shown to carry a benefit. And so the increased cost and resource utilization and the catheter-related issues was sort of judged by many centers to be not worth it. And so largely across the United States, the use of intraperitoneal chemotherapy in the adjuvant after surgery setting has largely stopped, and people have gone back mostly to intravenous chemotherapy at most centers. So how else can we enhance treatment of the peritoneum? Well, in some ways we already do. We know and have known for 30 years that surgical resection, which we call cytoreduction, is a cornerstone of therapy in ovarian cancer, and one of the most important ways in which patients can achieve clinical remission and survive their cancer. And there are both theoretical benefits, such as the sort of quick improvement in symptoms after they recover from a surgery, rather than very gradual improvement over the course of a long regimen of chemotherapy. Their GI function can improve if we drain all their ascites and remove large peritoneal deposits. They have a return of their appetite and better nutritional status when they do go on to systemic chemotherapy. And then one of the open questions that we sort of haven't fully answered is why a disease that is chemosensitive at the outset becomes chemotherapy resistant in many cases over time. People think that if you remove that there could be sort of chemo-resistant clones inherent in any large bulk of ovarian cancer, and if you can remove those surgically prior to putting essentially like a selection pressure on them by killing all the chemotherapy sensitive cells, then you might prevent the recurrence of chemotherapy-resistant disease in the future, where only those chemo-resistant clones are continuing to grow, and they're no longer fighting against other cancer cells for oxygen and nutrients in the tumor microenvironment. And we know that there are clinically measurable benefits from the cytoreduction as well. So those are the theoretical reasons why we take people to surgery and do big surgeries. But what are the clinically measurable benefits? Well, we have improvements in progression-free and overall survival in a lot of old studies that looked at how much measurable disease could be left and how much benefit was being gained by increasing efforts at surgical cytoreduction and increasingly radical surgery. but these are not randomized data. There's no randomized data for debulking patients or not. There's just very large series of mostly retrospective cohorts showing the improvement in complete clinical remission and in overall survival for patients who have minimal or microscopic residual disease after a surgery. And these are just some of the old Kaplan-Meier curves from some of those trials, including a paper by Hensley on the left in the mid-2000s, where they looked at patients who were left with implants that were 1 centimeter in size compared to, I'm going to put the pointer on for a second. Let me see if I can spotlight. Let's see. Oop, it's not letting me do that. Sorry. I thought I was going to be able to use a pointer on this. I apologize. But in any event, on the graph on the left, we have sort of the poorest performing curve, our patients who had surgery where they had 1 centimeter implants left. But where we want our patients to be is on the blue curve on the top line. And that's where patients who had only microscopic disease left after surgery, with the top graph showing their chance for progression-free survival, where their cancer doesn't grow or reoccur, and then their overall survival from the time of their cancer diagnosis. And the importance of surgery in patients who are otherwise treated with the same chemotherapy regimen in moving patients from that lower curve to that highest curve. And so what are other ways that we can directly affect the abdominal cavity? Well, there's quite a bit of data on the translational data and mouse model data on the effects of hyperthermia in the peritoneal space and on cancer cells. And so we know that hyperthermia, which would be 41 to 45 degrees Celsius, is associated with increases in penetration of chemotherapy at the peritoneal surface, because it starts to break down some of the cell surface adhesion molecules that will make that surface more absorbent of chemotherapy. It increases the sensitivity of the cancer to chemotherapy by impairing DNA repair while the temperature is elevated. It can induce apoptosis and activate heat shock proteins from some of the most metabolically active cells, which are going to be the cancer cells on the peritoneal surface, increasing oxygen free radical formation, which is another mechanism by which we kill cancer cells, and increasing overall cellular metabolism that can increase cellular uptake of the drug. These things have been shown sort of in a lot of, again, animal models and translational research. And so if we sort of think about the tools that we have to sterilize the peritoneal cavity, we know that surgical debulking helps. We know that hyperthermia can kill cancer cells. And we know that high-dose intraperitoneal chemotherapy can kill cancer cells. And so why not try to do all those things at once? And so that's been done. And there's, I think folks who have been my mentors along my training and in practice sort of use the phrase sometimes, what's old is new again. And it's the reference to how things can sort of fall in and out of favor in medicine, and how as improvements occur in one area or another that touches an intervention, that intervention might gain utility or lose utility over time. And so a procedure that is not new by any stretch of the imagination, that was developed and really popularized in the late 80s and the 90s by Paul Sugarbaker for the treatment of gastrointestinal and appendiceal tumors, is called HIPEC, hyperthermic intraperitoneal chemotherapy. And it's a treatment that's done at the end of a cytoreductive surgery performed to remove cancer. And it's really ideally suited for these diseases that like to spread along the peritoneal surface, which includes appendiceal cancer, gastric cancer, various GI mucinous tumors, pancreatic cancer, mesothelioma was really Paul Sugarbaker's specialty, and of course, ovarian cancer. That's how many of our patients get in trouble with ovarian cancer. So over the course of time, there have been various approaches and ways that people have done HIPEC and chemotherapy regimens that have been used for tumors that originate from different disease sites. And the experiences over time have been variable. In the early days of this, there was a lot of morbidity, and this procedure was sort of regarded with some trepidation by many providers and by patients. But I think one of the things that we see now in modern cohorts and in some of the data that I'm going to go through and show you is that we understand much better how to get patients through large surgeries and how to do large volume resuscitation and support them. And our anesthesia supports are much better than 30 years ago. Our ICU supports are much better than 30 years ago. And so a lot of the safety parameters around applying HIPEC chemotherapy to patients are much better than they were when the procedure was first developed. So how is this done? If we're going to do this for ovarian cancer, how is HIPEC even administered? And really what the principles are is that in the graphic in the left upper corner, you can see the sort of basic schema is that you have the patient with their peritoneal cavity exposed, and you need to take a large volume of fluid and create a circuit. So you can wash fluid through the abdomen and keep it sort of going in a forward pump. So you use a pump, a roller pump, that also has a heat exchanger capacity that it can regulate the temperature of that fluid. And you need an inflow and an outflow tube where the tubing is essentially sterile at first. So you open it from sterile packaging onto the field and you sterilely place tubing into the abdominal cavity. And then the other end of the tubing can be passed down to off the field, down to the pump. It's all hooked together, and through this circuit of the abdomen, the roller heater pump, the inflow tube, and the outflow tube, you start to perfuse this fluid, which in our case is saline, is often used. There are some other glucose-based solutions that can be used for other regimens, but saline is probably the most common one. And then how you actually prepare and arrange the patient's abdomen for this procedure sort of falls into two general techniques. There's a closed technique and an open or Coliseum technique. And what's pictured in the lower left-hand corner is the closed technique, where the inflow tubing and the outflow tubing are in the peritoneal cavity and the abdominal wall is temporarily closed around the catheters to create more of a closed circuit. And there are temperature probes attached to the inflow and outflow tubing so that we understand what the temperature is in the patient's abdomen. The opposite is the two pictures on the right, which is the Coliseum technique, which is more frequently done, I would say, outside of the United States, where self-retaining retractor is utilized around the abdominal incision, and the skin is sort of sutured or clipped up to the ring. And then the tubes are sort of handheld by the surgeon and moved around the abdominal cavity to distribute the perfusate around the abdominal cavity. Again, in the United States, mostly people are doing the closed technique, which has some benefits of bringing the abdominal temperature up more efficiently, and also protecting some of the operating room staff from the potential to spill any of this chemotherapy, which is not what we would want to see. That's not, you don't want to have any spills. You want it all to be in a contained system. So how are we doing it? We do the operation. We do these operations now. We have tremendous experience in our group doing these surgeries multiple times a month for patients who have advanced ovarian cancer. So we complete the operation, we remove any visible cancer, and we insert this tubing into the abdominal cavity. We close the abdomen. We start this forward pump circuit of the saline fluid, and then we inject the appropriate dose of chemotherapy into the perfusate, and it keeps going. And we monitor the patient carefully. We monitor their core body temperature. Our anesthesiologists are administering fluids and other pre-medications. And the abdomen is heated to achieve a tissue temperature of about 41 degrees Celsius. Who are we going to do this to? Who are the patients who we think are going to benefit the most from this? We're going to start with patients with stage 3 epithelial ovarian cancer. And these are going to be patients who have a high burden of peritoneal involvement of their abdomen. That's why they have stage 3 disease. They're going to be patients who've received some of their chemotherapy already, which is a term we use called neoadjuvant chemotherapy. We're going to know that they're responding to that treatment. The platinum chemotherapy is working to treat their cancer, which it does for about 80% of our patients at least. They're going to have good functional reserve to receive an additional dose of chemotherapy at the time of surgery, including good kidney function to flush this chemotherapy out, and good bone marrow function to recover their white blood cells and their red blood cells and their platelets after surgery. And these need to be patients who are otherwise healthy for surgery, because one of the true things about ovarian cancer surgery is that it's one of the more radical surgeries that are done in the abdomen. Sometimes our patients have bowel surgery. Sometimes our patients have their spleen removed. Sometimes our patients have partial liver surgeries, all in addition to a hysterectomy. It's all with the goal of removing any visible cancer. So these are big surgeries, whether you're doing HIPEC or not, and the patients need to be medically fit to get through the surgery. So that's part of the consideration as well. So what are the data, right? We've sort of I presented this as kind of a hypothetical, like this would be a really good idea for this patient population. But of course, we practice evidence-based medicine. And so there are a number of retrospective and prospective cohort studies that have looked at this. But then more recently, there have been some randomized trials that have really made a strong argument for utilizing this treatment for this specific patient population. And the landmark trial really was the HIPEC-1 trial, which was published in the New England Journal right at the end of 2018, early 2019. And this was a phase 3 randomized controlled trial. So this was really level 1 evidence exploring the role for intraperitoneal hyperthermic chemotherapy at the end of debulking surgery for these patients. My slide is stuck again. There we go. So who did they enroll in this study? These were newly diagnosed patients with stage 3 ovarian cancer, fallopian tube, or primary peritoneal cancer. They had been referred to have neoadjuvant chemotherapy because their disease was initially judged to be non-resectable. They may or may not have had exploratory laparotomy to make that assessment, something that we kind of refer to as a peek and shriek, or an initial attempt that was unsuccessful at removing their tumor. They have a good World Health Organization performance status, and they've received our standard regimen of carboplatin and paclitaxel for their preoperative and their postoperative chemotherapy. And patients were registered for the trial preoperatively, but then their randomization wasn't done until the surgeon got in and said, okay, this is a patient who I can cytoreduce. We've taken this patient to the operating room because we thought surgery today was appropriate. I've opened their belly. I think I can cytoreduce them. And then they're randomized. Am I going to do surgery alone, or am I going to do surgery and give them HIPEC at the end? And then everybody went on to get the same postoperative therapy, and they had the same surgical effort. And the study intervention was the heated cisplatin at a dose of 100 milligrams per meter squared intraperitoneal for 90 minutes. And their endpoints were recurrence-free survival and overall survival. And then they also looked at safety data, and they looked at quality of life. They enrolled almost 250 women in 8 centers, and they split them 1-to-1. And you can see in the table to the left, to the right, excuse me, that these were pretty healthy patients, usually in their 60s. Many of them had high-grade serous ovarian cancer, which is our most common histology. One of the things that we think about a lot in GYN oncology is how our disease site is not the only thing that drives cancer biology, and how some of our different histologies actually have different underlying molecular drivers and molecular changes. And so it's important to know that the vast majority of patients in this study were high-grade serous patients. And most of them had a complete cytoreduction. So most of them had about 2/3, 70% had no visible tumor, and a smaller percentage, about 30%, had either tiny nodules, what we call miliary disease, less than 2.5 millimeters, or implants slightly bigger, up to 1 centimeter, but still what we would consider optimal surgery. About 25% of patients had a bowel resection, and some had an ostomy placed or not, and I'll talk about that. The duration of hospitalization was slightly different by about a day or so, and the median time to receiving first chemotherapy after surgery was not different, and the total number of completed doses of chemotherapy after surgery, which is part of what is otherwise the standard of care, was not different. So importantly, the patients had an improvement in their progression-free, their recurrence-free survival of about 4 months. And then they had a significant improvement of about 1 year in their overall survival. And, you know, we want patients to live a lot longer than 1 year or 1 additional year. But I think when you look at all the interventions we have to do to keep patients alive with ovarian cancer, with the different recurrence therapies that are available, with the different maintenance therapies that are available, and the nature of clinical trials, when you're testing in a randomized fashion one intervention, to see a 1 year improvement overall survival is actually pretty big for ovarian cancer. In many cases, we can only affect progression-free survival because so many of the things that happen in later line therapies to the patients that were on the trial sort of cross over, and some of the survival benefit gets lost. So this was a pretty stark outcome and pretty exciting. And they just presented an update with about 10 years of follow-up data at the ASCO meeting in June of 2023, showing that the progression-free survival benefit remained about 4 months, and the overall survival benefit remained about 11 to 12 months. And the therapies in subsequent lines of treatment for the two arms were pretty balanced. The number of people who went on to receive at some point down the line platinum-based chemotherapy or non-platinum-based chemotherapy, the number of patients who used maintenance strategies, including PARP inhibitors or bevacizumab, was the same, and the number of patients who underwent secondary cytoreduction if they had a platinum-sensitive recurrence was balanced. And one thing that I'll sort of highlight here is that the median number of subsequent lines of therapy was 2. That probably reflects the fact that this trial was done in Europe, where the overall approach to recurrent ovarian cancer is, I think many people would say, is maybe slightly different than what it is in the United States in terms of how aggressively chemotherapy is used, when treatment is stopped, when palliative care is engaged. And so I think that's something to highlight, is that these patients didn't have 4 or 5 or 6 lines on average. They had about 2 subsequent lines of therapy on average. But over the course of all that follow-up time, their survival advantage, really did not diminish. Adverse events, it's really important to know that the severe toxicities, which are graded as grade 3 or grade 4, there was no difference in any of them. One thing that is notable here is that the discretion of whether or not to divert the bowel if chemotherapy had been administered and a reanastomosis of the bowel was required, that was left up to surgeon discretion. There was no specific guidelines given in the trial protocol. And what they saw was that the surgeons in the trial seemed a little nervous about not making a stoma if the patients had chemotherapy, and they noted an elevated rate of stoma formation. There's some other studies that have come out. There's a nice series from Cleveland Clinic where they looked at their HIPEC data and their anastomotic leak rates and suggested that diverting ostomy is not necessary just for the administration of HIPEC chemotherapy, but that's not something that we have randomized data about. But again, importantly, greater than 90% of patients in both arms completed all 3 additional cycles of chemotherapy, and there were no significant delays in administration of the next chemotherapy, which is important. This has been incorporated into NCCN guidelines for the last couple of years. This is not, considered an experimental treatment anymore. This is considered a reasonable standard option for patients with stage 3 ovarian cancer who've received neoadjuvant chemotherapy, utilizing this cisplatin dosing regimen. And so that's the regimen that we're going to be using when we launch our program this fall, which we're very excited about. A couple of other studies that I just want to highlight, because I think it's helpful to sort of think about, again, who really benefits from this and how should this tool be used compared to other tools for ovarian cancer. This was a Korean trial that included patients with either stage 3 or stage 4 ovarian cancer. And the patients either had surgery, either had cancer that was amenable to sort of upfront surgery, or had that heavier burden of carcinomatosis that required neoadjuvant chemotherapy. And their intervention was, cisplatin at a dose of 75 milligrams per meter squared for 90 minutes. So a little bit less chemotherapy, but still a 90-minute duration of exposure, heated to about the same temperature. So again, looking at who was enrolled in this trial, about half, roughly, of the patients were stage 3, and about almost half were, a little less than half were stage 4, about 40%-ish versus about 55, maybe 60% were stage 3. One of the other things that's clear is that this does make surgery longer. Their median OR time was exactly 120 minutes longer, which is about how long it takes to about 30 minutes of additional sort of setup and takedown, plus 90 minutes of what those of us who do these cases refer to as shake and bake while the chemotherapy is perfusing. And so thinking about this population of people who had, either upfront resection of cancer, or maybe even patients who had stage 4 disease, when they looked at their overall population, they actually did not see an improvement in progression-free or overall survival. And that's important to know, is that this isn't necessarily the best tool for every single patient with ovarian cancer. But when they did a subgroup analysis on patients with undergoing neoadjuvant chemotherapy with interval cytoreductive surgery in stage 3, they showed that they had a significant difference in their progression-free, and overall survival. So patient selection matters. And stage 4, when the disease is diagnosed outside the peritoneal cavity at presentation, may be a situation where sterilizing the peritoneal cavity just doesn't make that much difference in the end because of the systemic nature of the disease rather than the regional nature of the disease. A second supporting trial was done in Spain. Again, these patients were included if they had stage 3 or stage 4, but they were only neoadjuvant chemotherapy patients. Again, their intervention was a lower dose of cisplatin and for a shorter duration, about 60 minutes rather than 90 minutes. And what they found was a statistically significant improvement in disease-free survival and overall survival, but it was a smaller benefit. So it was about a 6-month benefit in progression-free survival, but only about a 7-month benefit overall in overall survival. So, whether there's an optimal dose here or an optimal duration, if 75 versus 100 matters, if 60 minutes versus 90 minutes matters, we haven't asked those specific questions in a randomized trial, but we may find over time as more data comes out that we really can refine how we use this tool and how much OR time and anesthesia the patients are exposed to. So again, beginning this fall, hopefully in about a month, we will be offering this to patients with ovarian cancer. We've been working for the last year with our wonderful collaborative colleagues in anesthesia, nursing, OR nursing, intensive care, our floor nurses, our perfusion team, to sort of get all of the protocols in place to launch this program. We're very excited about it. And we're, once we have this program up and running, we have a lot of questions we want to ask and contribute to the literature around this. And we're looking forward to figuring out what the optimal dose is, what the optimal duration is, and hopefully working with some collaborators to develop some biomarker predictions for who's going to benefit the most. Because I think one of the things that the trials have shown us is that maybe not everybody needs this, but there are clearly patients who benefit, and we want to personalize and use precision medicine and use this tool, like all of our other tools, for people who are going to benefit the most. I'm going to switch gears a little bit and talk about targeted therapies. So, the first part of this talk, we're really using the same tools that we've used before in sort of creative new ways. We're using surgery, we're using chemotherapy. That's been our toolkit. We're using hyperthermia, but, that's been our toolkit for a long time. And so we now have molecularly targeted therapies like bevacizumab, which has been around for about a decade, and PARP inhibitors, which have been around for the better part of a decade now. And we could sort of spend some time talking about the optimal use of those. But I think what's sort of more exciting are kind of a newer class of drugs that are coming on the scene that I think folks who don't treat cancer patients all the time are going to start seeing their patients on these medications, or they may hear their patients talking about these therapies. And these are things that if you've been in practice for, 5 to 10 years, these were not even probably discussed when you were in medical school. And so you probably want to get caught up on what these things are. And so what I'm talking about are antibody drug conjugates. And it's sort of a complex medication because what it is biochemically is the joining of a monoclonal antibody that's going to target some receptor on the cell surface of a cancer cell. And it is linked by a cleavable linker. So there's a chemical bond there basically that's going to be broken down in a lysosome. And attached to it is something that the pharmacists call a payload, which is some kind of cytotoxic compound that's going to kill that cancer cell. And sometimes these antibody drug conjugates, the payload actually have then a bystander effect where it kills the cell that absorbed it. And then as the cell breaks down and apoptosis occurs, it releases that cytotoxic payload into the nearby cells, and those cells are killed too, even if they didn't express the original receptor that the antibody bound to. So there are a number of these drugs that are being developed and brought through the clinical trial pipeline for a variety of disease sites. But we're going to focus first on one that recently received FDA approval in ovarian cancer, and one that a lot of our patients are being screened for to potentially use, and we've started using and are seeing some really nice results. So the drug that I'm talking about is called mirvetuximab soravtansine, because why wouldn't you make it something that's incredibly hard to pronounce? It has a brand name, which I'll reference later on, because it's not really possible to use some of the material without referencing that brand name, but it is under patent, so there's not currently a generic available. But this antibody drug conjugate, the mirvetuximab, is an anti-folate receptor alpha monoclonal antibody. So that's the targeted part. And then the soravtansine is a microtubule inhibitor called DM4, which is a cytotoxic payload. And this drug got accelerated FDA approval in November of 2022 for platinum-resistant, folate receptor alpha positive, epithelial, ovarian, fallopian tube, or peritoneal cancer. And this is exciting because we haven't had a new therapy for platinum-resistant ovarian cancer in about a decade. Since the addition of bevacizumab to chemotherapy, which was about 10 years ago that the Aurelia trial came out. So how does it work? So the drug is infused. These antibody drug conjugates are infusional drugs, at least at this point, the mirvetuximab is. And it circulates in the bloodstream, and the cancer cells, if they are highly expressing the folate receptor alpha, it will bind to the little green receptor that's on the cell surface. It gets internalized into a lysosome, endosome, which then goes through sort of evolution and transfers the compound into a lysosome where the cleaver, the linker is cleaved. And then the drug is sort of free to be absorbed into the nucleus and cause DNA damage and essentially kill the cell. So how do we know this works? How do we know that this is something we should use for ovarian cancer? Well, obviously, again, we use evidence-based medicine, and there are a number of studies that have been done looking at the utilization of this drug in ovarian cancer. And this Soraya study that I'm sort of highlighting here is one that was done internationally, including with some local collaborators through the Harvard Cancer Center, who recruited patients from, I think, 8 different countries. So what they looked at were patients with recurrent high-grade serous ovarian cancer. So again, that's our most common histologic type, the one that's most likely to be diagnosed in an advanced stage and to sort of have, unfortunately, high recurrence rates over time. These patients all had previous therapy, anywhere from 1 to 3 prior lines, and they were all identified as having high folate receptor alpha expression levels using an FDA-approved companion diagnostic test where at least 75% of the viable cancer cells were found to have 2 to 3 plus expression of the folate receptor alpha protein by an immunohistochemistry assay. So they had to be diagnosed with this or identified as having this biomarker, the folate receptor alpha, at a high level, and then they would potentially be available for this therapy. So this was a single-arm phase 2 trial, so there's no control arm in this trial. They screened patients actually in 11 countries and ended up enrolling, I think, in 8 countries. They screened almost 500 patients, 467. And one thing I wanted to highlight is that their screening positive rate was 36%. So if we think about all of our patients who have ovarian cancer who progress on their disease and have platinum-resistant ovarian cancer, we anticipate that about a third of those patients are going to have this high level of folate receptor alpha expression that's going to allow them to be eligible for this drug as a single agent. And so after they went through their screening, they enrolled 106 patients in the trial, and they were able to analyze them. Most of these patients had a prior platinum-free interval of at least 12 months. So it had been at least 12 months since they finished some platinum-based chemotherapy. Their initial primary platinum interval was at least 12 months in the majority of patients. And so these were patients who their first recurrence was probably platinum sensitive, but their most recent platinum-free interval would have been less than 6 months because they needed to be platinum resistant to enter the trial. And so about 2/3 had somewhere between 3 and 6 months since their last therapy, and about a third of patients had anywhere from no progression-free survival to only 3 months since progression until progression from their last treatment. They were healthy patients. About 20% of them had a BRCA mutation, which reflects the sort of rate of germline BRCA mutations overall in this population. They had about half of them had been pretty heavily pretreated with 3 prior lines of therapy, and a lot of them had received our usual standards of care, which is that most of our patients received platinum-containing drugs, most of our patients received taxanes, most of our patients now in the modern era receive PARP inhibitors for maintenance, and many have received bevacizumab for maintenance. And so their outcomes showed basically an overall response rate of about 35%. About 1/3 of patients had a drop in their measurable disease of at least 30%. And so if you look at the waterfall plot on the top, they're actually showing you the percentage change of the target measurable lesions on a CT scan for every patient in the trial. And they've sort of organized the patients from the people who had the worst outcome on the left to the people who had the best outcome on the right. And they're showing you horizontal bars for where the categorization falls for people to have progressive disease if they have more than 20% growth, to have stable disease if their biggest change from baseline was within the 2 bars, to have a partial response if their tumor shrank but did not complete by at least 30% but did not completely go away. And then they have some complete responses where they have 100% regression. There's no visible disease left. That's a complete response. And overall response rates is everybody with a complete or partial response. And that totaled about 1/3 of the patient population, but there's another almost half of the patient population who had no progression of their cancer. Their cancer was basically largely stable. And that's something that a lot of trials are now reporting out as a disease control rate, where progression, where sort of complete, partial, and stable disease are all sort of lumped together. Safety, obviously, is really important. And so the other thing I want to highlight in this slide, I'm sorry, is that so the median progression-free survival for the overall cohort was only about 4 months. But for patients who did respond, the median duration response was about 7 months, which is better than systemic chemotherapy. And for historical references, the other option for these patients would be another single-agent non-platinum-based chemotherapy, where the overall response rate would be expected to be as low as 10%. And these were about 33% in this trial. So a much higher chance, 1 in 3 patients is going to have a measurable response versus 1 in 10 patients with chemotherapy. The most important and sort of unique safety issues with this drug are visual related changes. So the manufacturer recommends a baseline ophthalmic evaluation and then evaluation every 8 weeks with proactive use of moisturizing eye drops and ophthalmic steroid drops. And there's a whole regimen that gets prescribed as patients start on this medication. But blurry vision and keratopathy are probably the 2 most significant grade 3 or 4 events. And those are things that our medical oncologists need to hold the drug for and wait for it to resolve before they can re-prescribe it. And so that's something that's a little bit unique that we don't see with the other tools that we use with ovarian cancer, but something that our medical oncologists are becoming more and more sort of equipped at handling, and our ophthalmologists and optometrists are helping us with slit lamp exams to make these corneal assessments. And so it does come as a boxed warning on the FDA label that you can see here the brand name of the drug that has FDA approval can cause severe ocular toxicities, including visual impairment, keratopathy, dry eye, and eye pain. The ophthalmic evaluation is recommended prior to the initiation of the drug, and for the first 8 cycles, every other cycle. So basically every 6 weeks, 6 to 8 weeks. Artificial tears and ophthalmic steroids are recommended prophylactically and may be required in an escalated fashion if severe toxicity develops. And for patients who have toxicity, they can have a dose reduction. And I took from the package insert here in table 2, you see the dose reduction schedule, where the actual adjusted ideal body weight is the dosing base in milligrams per kilograms. And you start at 6 and you can drop as low as 4 as needed for any toxicities that may occur. So the other thing that's kind of exciting that there's been some emerging data on are the patients who don't have quite that same high level of folate receptor alpha expression. And so this report came out this year in GYN Oncology, a phase 1b/2 multi-cohort study. This was industry sponsored, so I want to highlight that and acknowledge that, but they were evaluating this drug in combination with other drugs that are available for use in this population in patients who express a lower level of folate receptor alpha. So they don't have that 75% threshold to get single agent mirvetuximab, but could they get mirvetuximab plus something else if they have some expression of folate receptor alpha? So this report was in combination with bevacizumab, which is an vascular endothelial growth factor receptor monoclonal antibody that's used commonly in combination with a lot of chemotherapy and with maintenance therapy in ovarian cancer. And so they enrolled patients with platinum-resistant ovarian cancer with 1 to 3 prior lines of therapy. And they were really looking at this population who had between 25 and 75% expression levels by the same immunohistochemistry criteria that was all centrally reviewed. They excluded any patients who had contraindications to bevacizumab, which includes uncontrolled hypertension or proteinuria or a history of GI perforations or fistulas. And from a mirvetuximab standpoint, they excluded anybody with active corneal disease. And so you can see they enrolled about 94 patients, most of whom had epithelial ovarian cancer, but there were some fallopian tube cancers. About half of this cohort actually did have high expression because they actually enrolled before the other study came out and sort of had proven that single agent therapy would be a potential option for those patients. But about half the population did have either 25 to 50% or 50 to 75% expression levels. And a lot of these patients are treated with our standard prior treatments. There are people who would have had taxanes, would have had potentially prior bevacizumab, and would have had potentially prior PARP inhibitors as maintenance therapies. And then the efficacy measures are here on the right. Overall response rate. Here they have a confirmed overall response rate of about 45%, 44%, which is a little higher than the other study population. Again, had a significant number of patients with stable disease. So really only a very small number of patients, only 8 patients in the total cohort, had significant progression and growth by sort of measurement criteria. They also saw a little bit longer duration of response in this study, to almost 10 months median duration of response among the people who did respond. And the median progression-free survival was about 8 months. Again, which is better than the about 3.5 months, which is sort of the historical comparison for chemotherapy alone. So they broke it out a little bit in patients who they sort of show in the upper left graph the overall progression-free survival for the population. And then in part B, they break it out by level of folate receptor alpha expression. And what it shows is that the drug combination works best in patients who have the highest level of folate receptor alpha expression. They had the longest progression-free survival. But there was a reasonable amount of survival across groups. And there were actually not statistically significant differences between those. They did show that the patients who were pre-treated with bevacizumab may have had a little bit less robust response because they'd already been exposed to that drug, but there was still a significant benefit with a PFS median of over 6 months, even in the pre-treated population. Adverse events are always important when we're combining new agents. And what you see here under the grade 3 and 4 toxicities was there were no grade 4 toxicities, but there was a lot of hypertension, which is a direct result of bevacizumab and has been seen in all previous trials that include that drug. And then the other grade 3 toxicities include dry eye, thrombocytopenia can be a problem with bevacizumab, and other rare outcomes that are seen with a variety, like abnormal liver tests and nausea vomiting that's severe, is seen with a variety of different cancer therapies that we utilize. So another trial that I just want to highlight, sort of we're running pretty close to an hour here, but I wanted to talk about one other drug that we're starting to use, not only in ovarian cancer, but in other GYN cancers. This was a sort of a biomarker-driven trial for HER2 expressing solid tumors called the Destiny PAN-02 trial. This was also presented at ASCO this year. And this was a phase 2 trial of HER2 expressing solid tumors with prior lines of therapy, trialing this new antibody drug conjugate, which combines a monoclonal antibody against the HER2 protein, which is called trastuzumab. That's a drug that many people have heard of, utilized in breast cancer for a long time, and one that actually the original form of trastuzumab has now been utilized for several years in high-grade serous endometrial cancer. But this is a new version, again, with a cleavable linker to topoisomerase I inhibitor, so a chemotherapeutic compound called deruxtecan, sort of a relative of like topotecan or irinotecan. And so they put a bunch of different solid tumors in this trial: cervical, endometrial, ovarian, pancreatic, bladder, biliary tract, and a group that they labeled as others, which included people with head and neck cancer, as well as extramammary Paget's disease, interestingly. And so they quantified the HER2 expression. Again, this is biomarker driven by centrally reviewed immunohistochemistry, and patients who had either 2+ or 3+ could be enrolled. Excuse me, that's not true. Patients who had 1, 2, or 3+ could be enrolled, but they broke out their analysis by level of HER2 expression, and patients had a median of 2 prior lines of therapy. So their results, I sort of cut off some of the other disease sites that aren't so relevant to us in GYN, but we can see in the rightmost column, these are the ovarian cancer results. And the confirmed response rate by central review was 45%, with 10% complete response and 35% partial response, which is really remarkable overall. And when you look at the highest expression levels, so the patients who had 3+ immunohistochemistry, the confirmed response rate was almost 65%, and still almost 40% for the 2+. So these are small numbers, but really promising data, where the duration of response for at least 3 months was 70%, and the median duration of response in these ovarian cancer patients was almost a year. So pretty exciting. This is not FDA approved. I was just looking this up online again to make sure I didn't miss any FDA press releases. But I don't think this is an off-label indication for this investigational drug, and so I should make it very clear that that is off-label. I think trastuzumab deruxtecan is FDA labeled for non-small cell lung cancer and for breast cancer with certain other prior treatments. But for these other disease sites, as a result of Destiny Pan-Tumor02, we are considering starting to use this, and I know we have at least one patient at the center now who is on this medication actually for endometrial cancer, but we're looking at it across disease types and screening our patients for HER2 expression now, regardless of their disease site, as we try to understand in each patient's case more what is the real molecular driver and what are the real molecular targets, and not just thinking in our traditional disease site treatment algorithms anymore. The most common severe toxicities were neutropenia, anemia, fatigue, and thrombocytopenia, which is not unexpected for a chemotherapy. One thing that was seen in this trial was almost an 8% rate of interstitial lung disease or pneumonitis, which were usually low grade and could resolve with holding the drug. But something just to be aware of is, as we sort of say sometimes in the cancer world, there is no free lunch. Every drug and every intervention that we're going to use, we know there's going to be toxicities. And so as we're using new tools, we need to understand what the toxicities are that we're not expecting, that may be different from traditional cytotoxic chemotherapy. And so it seems like interstitial lung disease may be one of those toxicities for this drug in particular. So what's in the beyond? What's coming up at BIDMC? We continue to be a very active recruiter into all of the Dana-Farber Harvard Cancer Center clinical trials programs, and we open those trials whenever feasible at BIDMC, so patients can have clinical trial access in our center. We have numerous phase 1 and 1B studies that are using additional targeted agents that we look at enrolling patients onto when we have molecular information available. And we're also building out relationships as a group within our GYN oncology division and also in our medical oncology GYN treatment team with other folks at BIDMC who do translational research on Fanconi anemia pathways and the role for PARP inhibitors, and some folks over at MIT are starting to work with us to try to understand some of the translational work that we could do as we launch this HIPEC program. And so within our division, we also continue to keep as our North Star what is best for our patients and delivering equitable care to them. And so we've been working actively to address financial toxicity, which is an inherent part of our cancer care delivery model right now, unfortunately, and it serves as a major driver in some of the delays in care that occur and disparities in cancer outcomes that occur. And so Dr. Essling continues to spearhead that work in our division and has developed a whole financial navigation program to help patients access resources that are available so that they don't have delays in their care and don't have disparities in their ultimate cancer outcome. So a lot of things that we're excited about and building on. I want to give a huge shout out to my partners, to Dr. Catherine Estlin, Joe Dotino, Leslie Garrett, who are the other surgeons in our group, John Dalrymple, who's our vice chair and another valued member of our department, although he does not see patients clinically anymore, and our amazing nurse practitioner and physician assistant in the group, and the nurses who we work with, all of whom provide a team approach. And I think one of the things I love about the work that we do here on behalf of our patients is that it is a team approach, we get the pleasure of being able to say, I think I can speak for everybody whose name is on the slide in saying that we get to do something that we love, and take care of patients who are really passionate about. So that's all I have. Hopefully there's maybe at least 1 or 2 questions in the chat. We'll see. I'm going to open up chat. I don't have any open questions at the moment, but if anybody has any, they're welcome to put them in, or you can reach out to us. I'm happy to take questions by email later on. Thank you very much.